Thank you, Rahul, and I enjoyed the talk by Arun very much. I'm just going to carry forward where Arun actually left off, and I'm going to talk something about how do we manage diabetes in the critical care settings. If you look back in history about how hospitalized patients were managed, initially the thought was that hyperglycemia is a protective phenomenon, and being hyperglycemic improves outcomes. Till the Vandenberg paper came in, and they showed that high glucose levels in the hospital, mind you, I'm saying high glucose levels, I'm not talking about patients with diabetes, but I'm talking even non-diabetic patients who develop hyperglycemia, which Arun alluded to during his talk. So patients who have high blood glucose levels when they were intensified in their control did much better than patients who had hyperglycemia. So based on all this, we realized somewhere in 2016 that the RSSDI has to come up with a white paper as to how to manage inpatient population for their glycemic control. And we brought out this clinical practice recommendations which we published in the IGDC. I was privileged to be part of that task force which brought out this white paper to be followed by hospitals across the country. And even Anjali is over here who was part of, Anuni was part of the white paper that we brought out. So this was the first paper that we actually published on managing inpatient hyperglycemia. And this is some kind of a guideline as to how Indian patients should be managed. Now this was basically a collective effort of a number of people which went in to give the recommendations. Let me point out that although we thought that hyperglycemia was a protective phenomenon, the earliest caveat to this came from Tony Fenario, who looked at post-cardiac surgical patients. Now, Tony Fenario was a cardiac surgeon, and he analyzed all his patients who were not doing very well and tried to figure out that what was the reason that they were not doing well. So he looked at all the patients who were not doing well, and they looked at the glucose control of all these patients. And what he really found was, as the blood glucose increases, so does the incidence of deep sternal wound infection as well as mortality increases. He also pointed out that if the first post-op day, the blood glucose was more than 200, then it increases the length of stay in the hospital. There's 3 times more chances of ventilation duration, and there was 7 times increased risk of mortality. So clearly you can see there was a distinct correlation between hyperglycemia and adverse outcomes. And this was the Vandenberg paper that I talked about. Dr. Vandenberg, which is also called as the Leuven paper, and they looked at the surgical ICU patients. These were mostly post-cardiac surgical patients. And they looked at 2 arms. One was the intensive arm, and the other one was the conventional arm. In the conventional arm, the blood glucose targeted was 180 to 200, and insulin was started for all the patients who had a blood glucose values of more than 210. In the intensive arm, the blood glucose target was between 80 to 110, and they were maintained in that narrow bandwidth. What they really found is that if you look at the outcomes, the mortality, the risk of bacteremia, the prolonged antibiotic use, prolonged ventilation, dialysis, and the ICU stay, all were much less in the intensive hours. So this kind of brought a whole new thought process in the critical care world, and we started thinking that probably the intensive control is the way to go. And there were a number of papers that came forth showing that intensive control really did well. And these were some of the papers that I can talk about, which really showed that, I'll just come to that in the subsequent slides, which showed that intensive control really did well in patients who were kept in the narrow bandwidth about 80 to 110. The other thing that you really need to understand is, this is another paper which is by Vandenberg, which showed that if the patients were randomized between 3 groups, more than 150, 110 to 150, and less than 110, the patients who had a lower blood glucose values did much better in terms of their outcome and hospital stay than patients who are in the upper bandwidth. Now, as Arul pointed out, that 140 was the cutoff point where we talk about hospital hyperglycemia. And mind you, here you're looking at just little above 150, the case that he mentioned about 150. And here you can see even within the normal range, patients who had slightly lower blood glucose values did much better than the upper values. Now, why do really hyperglycemia cause adverse outcomes? because you can see that hypoglycemia in the hospital causes a metabolic stress response. It increases the stress hormones and the peptide levels. And on one hand, it causes an immune dysfunction, infection dissemination. And on the other hand, it causes an increase in ROS, increase in transcription factors, and increase in secondary mediators. And ultimately, this leads to hyperglycemia, reduced insulin to cover up for the increased hyperglycemia, increase in mobilization of free fatty acids, ketones, and lactates, and ultimately all this culminates into cellular injury, apoptosis, inflammation, tissue damage, altered tissue, wound repair, which causes a prolonged hospital stay, disability, and death. Now, these were some of the studies, early studies that I was talking about earlier, where intensive control showed a clear benefit. And you can see some of these were in the ICU, medical surgical ICUs, CCUs, and you can see on the right side that there was a much reduction in the infection rates or mortality in the intensive arm groups. Now, based on this, of course, there was a lot of thought process that should we really universalize it and say that all patients in the hospital, especially in the critical care setting, should have intensive arm. And a number of studies then started coming forth which showed that as you intensify control, the risk of hypoglycemia increases, and so does the risk of mortality. So then they kind of started thinking that do we really need a very intensive control? And ultimately the issue was settled by the NICE sugar study, which was a prolonged, prospective study, a 7-year study. They looked at about 6,000 odd patients, and they found that there was no difference between 80 to 110 to 140 to 180. But the risk of hypoglycemia and death were much higher in the intensive arm. And finally, I think all of us have settled to the fact to say that our target glucose control in the critical care settings should be between 140 to 180. So that's where we stand at this point of time. And here's the meta-analysis and the forest plot of number of studies, and the risk of hypoglycemia 6 times as much in patients who are on intensive control. So we now come to this conclusion. Prior to 2000, there was no recommendation. The average blood glucose ranged between 200 to 240. Between 2001 and 2009, the AACE recommended, based on the Vandenberg study, a blood glucose target between 80 to 110. And 2009 onwards till now, we sort of recommend that 140 to 180 is the way to go. There's only a caveat that post-cardiac surgical patients probably do well when their targets are between 110 to 140. And I'm subsequently going to a case which is going to compare 110 to 140 versus 140 to 180 in the post-cardiac surgical patients, and I'll show you what the results showed up. Now, I'm going to show 4 cases because the glucose targets we're all universally agreed on should be between 140 to 180. What I really want to show you is 4 case scenarios in a critical care settings. How do you manage them? And I leave it to the chairpersons to stop me when I've exceeded my time. I'll just stop wherever I am. So the first case is of Mr. Naik, 48 years, 7 years of diabetes, 4 years of hypertension, has triple vessel disease for which he's been posted for a CABG. On his pre-op assessment, his blood pressures are 150 by 90, BMI is 27, nothing really remarkable in his clinical examination. On his labs, his fasting is 130, post-meal is 204, A1C is 7.5, UACR is 84, creat is 1.7, GFR is 43, ECG is normal, echo normal, ultrasound nothing much, eyes show an early non-proliferative diabetic retinopathy. And these were the current medications that the patient was on: Glargine of 24 units at bedtime, metformin, ramipril, and atorvastatin. The question that I want to ask you is, what should the glucose targets be for control in this patient? As I mentioned to you, that our target should be 140 to 180. Clearly, that has been shown in various studies, excepting in cardiac surgical patients, where we look at 110 by 1 to 140 as a target goal. And this was a Gluco-CABG trial that came up. And this was a very important trial done by Dr. Umpiras, a very close friend. And most of the slides, if you see, which even Arun projected, all of them are authored by Dr. Umpiras. And both of us work quite closely together. He's from Emory University. What he did was he compared 100 to 140 versus 140 to 180 in the post-cardiac surgical patients. And If you see here, the perioperative blood glucose of more than 140 was equally about in non-diabetic patients and diabetic patients in about 83% and 98%, and they started a continuous insulin infusion in most of these patients. What did they really show? Here you can see that in the pre-surgical period, they were really randomly controlled. In the ICU, they were very tightly controlled to stick between 110 to 140 versus 140 to 180. And after the patients were out of the ICU, all of them had a target goal of less than 140. That's how they sort of randomized the patients into. And if you look at the outcomes, the composite outcomes was really not very different, statistically significant between the two groups in terms of all the outcomes that you see here, whether it's death, wound infection, presence of pneumonia, acute kidney injury, respiratory failure, or MACE. If you look at the hypoglycemia rates, they were very similar between the two groups. So ultimately what they really concluded was that intensive insulin therapy to target between 100 to 140 in ICU did not significantly reduce perioperative complications compared to between 140 to 180 after CABG. In a subgroup analysis, it showed a number of complications were lower in the patients without diabetes, but not in patients with diabetes treated with the intensive regime, and large prospective randomized studies are required to confirm these findings. Just another point that I wanted to talk about, one of Arun's slides, and what he showed was that the patients who come into the hospital who develop new onset of hyperglycemia do actually worse off than the patients who are established diabetics and develop hyperglycemia. Because you can imagine that patients who are not hyperglycemic at the time of entry and become hyperglycemic, these are all stress hyperglycemic. They're more sicker patients, and that's why they have worse outcomes than patients who are established diabetics and develop hyperglycemia in the hospitalized environment. This is my second case, a 45-year-old diabetic for 6 years, admitted to ICU with left leg necrotizing fasciitis with septicemia, has been fairly well controlled on oral agents. The labs were total count of 22,000, polymorphs of 86%, random glucose of 456, ketones positive in the urine, no acidosis on the blood gases, urea 56, creat of 1.4, LFT is normal, culture sent. In this patient, how will you manage the patient's blood glucose is the key concern. Now, we have all been, of course, I keep reminding you of the targets with every case because this is something that we universally accept. This was our recommendation in the paper that we brought out from the RSSDI. And here you can see that how do you really calculate the patient's titration and how much of insulin to give. So let's say that most of the patients who are in ICU would be on an insulin infusion. They're all on IV insulin protocols and they would require an insulin pump. So how do you calculate how much should be a starting point of initiating insulin therapy for the patient? So you take the blood glucose, let's say it's about 400 as a starting point. So blood glucose divided by 100, it's a very crude way but a very useful way to start with. So it would be about 4 ml per hour. So you just divide blood glucose by 100 and that would be your insulin infusion rates. And you give a priming bolus of 0.1 units per kilogram of body weight. Remember that if you have given an infusion and you look at the rate of fall of the blood glucose, besides the absolute glucose values, you look at the rate of fall of the blood glucose. If you get a rate of fall of more than 30 mg%, then there is still an effect of the current regime that you're giving the patient. You don't change the infusion rates in the patient. If you get a fall of less than 30 mg%, then you increase the infusion rates. And if the blood glucose is, of course, much way up and much more than 30 mg%, then of course you need to sort of increase the infusion rates. And this was the insulin protocol that we mentioned in the white paper. And you can see here clearly that based on the rate of fall and the absolute value of blood glucoses, this was the insulin infusion rates that you can go by with the patient. Now, this is all published in the, and I can give you the paper or the reference. There we have, it's in the IJDC, and we can give this paper whoever wants it. Now, at some point of time, if you notice that the patient is going hypoglycemic and the blood glucose are less than 70, you hold the insulin, and you need to decide whether you need to give a dextrose for the patient or not. Commonly that we observe is that the trend is that you give 50 cc, 100 cc at random, and you say, okay, correct that. I think there should be some, because the patient then swings from hypo to real hyper, and then you have a trouble, you're trying to intensify further the insulin infusion. So the way to go about is you do blood glucose minus 100 into 0.8, and that would be the amount of dextrose that you give the patient. So there's an example that I've given right at the bottom. If the blood glucose is 40, then 100 minus 40 into 0.8, which is roughly about 48 ml that you need to give the patient's dextrose. And then if the blood glucose is less than 70, check your glucose every 15 minutes. If the blood glucose becomes more than 70, you check every 30 minutes till the blood glucose is more than 90. If it is more than 90, you check the blood glucose hourly. And if it is more than 180, you restart the infusion at half the rate that you were giving earlier the patient. For centers that don't have an infusion pump, we had also recommended that you can give it by the macro drip, and this were the infusion rates that were recommended by the drip method for giving your patients where infusion pumps are not available. I always get asked this question that do we really need to give analogs intravenously? So this paper was by Umpiras, and what he showed was that patients who were on DK, they were randomized into two groups. One group was getting regular insulin, the other group was getting analog. And then after the patient's ketoacidosis resolved, they were transferred onto subacute regime of regular plus NPH versus glargine plus glulysin. What they showed was there was no difference when you give regular versus analog when you give intravenously. Remember that all insulins, whether it's NPH, whether it's glargine, whether it's any insulin, given intravenously behaves like regular insulin. So if you're in a tight corner and you don't have an insulin, all insulins intravenously behave like regular insulins. So there's no difference when you're setting up an infusion. There's no need to give expensive analog insulins to the patient. You can give regular insulin. It works as good as analog insulins. But when you give subcutaneously, there is clear reduction in the hypoglycemia events when you give analog insulins versus a regular insulin. So the hypoglycemia of glargine plus glulysin were much lower than regular plus NPH. This has already been mentioned by Arun, that in the ICUs, we give regular insulin IV. When the patient is transitioned to the wards, you give basal bolus. And very often at the time of discharge, you may either give premix, depending on what the blood glucose values and the admission A1Cs are, either premixed or a basal bolus. And that's how you titrate it post-discharge the patient. There are certain rules to be followed when you give transitioning the patient from IV to subacute. You always transition when the patient is able to tolerate solid foods. You give 2 hours prior a subacute injection and then stop the IV infusion. Do not stop the IV infusion and then give a subacute infusion. Do not transition from an IV to oral, or you have to give always the basal nutritional coverage and very often a correction bolus, as Arun pointed out. So this is what he actually has spoken, and I'm not really going to go over it again. So you have basal, bolus, and correction, which is really affected the way he showed in terms of calculation, and that's how the total amount of insulin is what you give the patient prandially. All right, this is my next case. Am I still on time? I still have time?
One you can do one.
Okay, so stop me if I don't have time, okay? This is a 55-year-old female admitted to the ICU with COPD and exacerbation for the last 3 days. Patient had moderate to severe respiratory distress. The patient had a 4-year history of diabetes and was being treated with metformin. She was supposed to receive prednisolone 40 milligram per day for the next 5 days. The lab results were A1C of 7.6. Blood glucose prior to prednisolone therapy was 144. Blood glucose on the following day was 188 in the morning and 211 by lunchtime. What is your best option that you've got to give the patient? Would you give a basal bolus to the patient? Would you give a basal at night plus NPH in the morning? Would you give a GLP-1 RA, or would you give a DPP-4 plus basal insulin? Remember that why does somebody on steroids really develop hyperglycemia? It's because of suppression of insulin secretion, increased gluconeogenesis, decreased glucose uptake from the blunted insulin sensitivity. Prolonged use can cause beta cell dysfunction with impaired insulin release in dose-dependent manner, and the glycemic effect of short-acting steroids is often exaggerated in prandial hyperglycemia and has little effect on the fasting blood glucose. Now, this was a very nice paper. What they looked at was 3 sets of populations. One was type 2 diabetics. The second was at-risk population for diabetes. And the third population was normal glucose tolerance patients. And what they looked at was they gave 3 days of steroids and the impact of the steroids on blood glucose levels, insulin, and the C-peptides. And clearly you can see here that when you give a steroid to the patient, the hypoglycemic response actually occurs from the midday to midnight onwards. And if you look at the insulin graph, you tend to get an insulin suppression in the first half and then followed by the, a sort of a surge in the insulin levels. So if you see any patient whom you give steroids, a long-acting particularly, you get a surge, the glucose surge that occurs is between midday to midnight. And the recommendation is to give NPH to all these patients. So the moment you give the steroid shot or a steroid orally, you combine it with an NPH because the NPH curve is such, the onset of action is about 4 to 6 hours, it peaks at about 8 to 10 hours, and the duration of action is about 16 to 18 hours. So by the time the glycemic surge is happening, the peak effect of NPH is occurring. So that's the reason, that's one of the strongest indications to use NPH in hospitalized patients is you have to combine it with steroids because it matches the action profiles of the glucose and the insulin kinetics. Now, when you have steroids and diabetes, would you like to treat it or not? So not all patients require intensive insulin therapy. If the blood glucose is less than 180, and the patient is on short courses of glucocorticoid, plus the patient gets minimal hyperglycemia, it may not require intervention. You can give correction sliding scale insulin, and these are sort of patients who are not diabetics. And this is, of course, patients who are on minimum duration of steroids. Now, if your blood glucose is more than 180 and the patient is on high dose steroids for a longer period of time, then you give it NPH, basal, and then, of course, correction boluses with short-acting insulin. Now, this is a recommendation of the Emery protocol, which is by Dr. Umpiras. This is in non-diabetic patients. If your patient is on oral steroids, blood glucose of more than 180 on more than 2 occasions, you start NPH insulin by 0.1 to 0.2 units per kilogram per day, or basal, glargine, or detamir. Start at 0.1 to 0.2, and then you can give correction doses with rapid-acting insulin. The way you calculate correction boluses is blood glucose minus 100 divided by the correction factor. And the correction factor is calculated if you're using, whether you're using regular or analog, so you give either 1500 or 1800 divided by the total daily dose. And that's how the entire correction factor is calculated, and the correction bolus is initiated on top of whatever baseline insulin that you're giving the patient. Now, if the patient's blood glucose is more than 180 persistently, then you can combine with NPH in the morning and give basal in the evening. The basal can be calculated as 0.2 units per kilogram and the NPH as 0.1 units per kilogram. Or you can give basal bolus, where the total daily dose is calculated as 0.4 to 0.5 units per kilogram per day. Half is given as basal and half as boluses. And you adjust the NPH or basal insulin accordingly. So if you're giving NPH in the morning, then you titrate the NPH based on the pre-dinner values. If you're giving basal at evening, you calculate as per the fasting glucose in the morning. Now, if your glucose values are between 140 to 200, you increase the next day by 10% the amount of insulin you give. If it is between 200 to 300, you increase by 20%. And if it is more than 300, by 30%. These are protocol for diabetic patients, very, very similar. In interest of time, I'm not really going to go into detail, but you just increase the amount of insulin that you give the patient as compared to the non-diabetic patients. You always talk about glucocorticoid equivalence. So when you're giving sort of any steroids, it is calculated on the terms of glucocorticoid equivalence. Are you going to look at blood glucoses of all the patients? So there's a clear directive. If your casual blood glucose is less than 200, consider the patient as low risk and record the blood glucose daily only post-meal. If your casual is less than 180, you can stop testing the patients. If it is more than 200, then the frequency of testing should be increased to minimum 3 times a day. In patients who are established diabetics, the casual glucose with more than 200, you of course estimate the blood glucose at least 3 times a day. And these were the protocols based on the glucocorticoid equivalents as to how much of NPH that you're going to give the patient. And for the different classes of steroids that you've got, this is how you calculate the amount of NPH that you're going to give the patient based on glucocorticoids. I don't think I have time for any further, right? Okay, so I'm going to stop and come to my last slide. I was going to talk about how do you manage with enteral and parental nutrition, but maybe we'll talk about it some other time. So my last slide is, of course, hypoglycemia is an independent risk factor for poor clinical outcome in multiple patient populations. Tight glycemic control improves mortality and morbidity and reduces cost in critically ill patients. We do not yet know what should be the optimum glycemic goals. Hospitalization is an opportunity to assess glycemic control and intensify the outpatient therapy. Until now, the issue has not been a priority. The barriers to good control is the gap between what we know and what we do. This is a photograph of Dr. Umpiraz and me, a very close friend, and this is what I've learned from him, and we have been working together for a long time over a period of years. Thank you very much for your patient hearing.